First of all, I'm going to thank Lily, the organizers, and Reed Session, and for asking me to speak on this occasion. And my apologies. First of all, when I came to know that I'm supposed to speak about diabetic kidney disease yesterday night at around 9 o'clock. So, but I've included some slides on that. But unfortunately, today, if the time does permit, first I'm going to discuss a little bit about the glycemic control in the hospital setting for the next 30 odd minutes, and subsequently, if time does permit, we might go ahead and have a little bit of discussion with diabetic nephropathy as well. There are some slides, but that's not going to be the main thing. Okay, so glycemic control in the hospital setting, all of these started in the late 90s, and people started looking into. If you look, that approximately 40% of all hospital admissions exhibit hyperglycemia, and out of these approximately 40%, 2/3 has a new onset hyperglycemia, and 1/3 has a history of hyperglycemia, which and they have a previous history of diabetes. In the hyperglycemia in hospitalized patients, which is defined as more than 200 milligrams per dl, and occurring in 38% of hospitalized patients, out of which 26% or 2/3 of patients have a history of diabetes, and 12% have no history of diabetes. Obviously, all of us are aware of diabetes does increase the rate of complications inside the hospital stay, but newly discovered hyperglycemia is associated with longer hospital stays, higher admission rates for intensive care units, and a less chance of discharge to home. I require a moment.
Yes.
Am I audible right at the back?
Yes.
Okay. Let's leave at that. Okay. So I won't go into details, but the majority of our patients are in the medicine services. All of you, why this happens is interior stress leads to increase in certain resistance in the peripheral tissues, or increased hepatic gluconeogenesis, release of contraindicated hormones, and along with release of insulin-rich cytokines, it leads to hyperglycemia, leads to worse outcomes. I'll quickly run through this slide so that we can have some sort of discussion with
इलेक्ट्रिकल प्रॉब्लम है
leads to poor hospital outcomes. It's because of metabolic distress response, either increase in glucose or decrease in insulin, kidney dysfunction, and increase chance of infection, increase in the biochemical mediators, increase free fatty acids, increase ketones and lactate, and increase in the inflammatory mediators of reactive oxygen species, and the secondary mediators of inflammation, thus leading to prolonged hospital stay, and mortality. And the types of hyperglycemia in the hospital setting, one is the group which has a long history of diabetes, others have a history of existing but unrecognized diabetes. The third group is the group of stress hyperglycemia. So stress hyperglycemia has been there for quite some time, since the early 90s, and this is due to the excess of contraindicated hormones, or leading to excess of hepatic gluconeogenesis, while the excess of contraindicated hormones and the cytokines, excess of increase in the hepatic glycogenolysis, again because of the contraindicated hormones and the cytokines, and insulin resistance at the receptor and the post-receptor levels as well, and all the peripheral tissues. And I won't go into great details about what's the difference between diabetes and stress hyperglycemia, but what is important is the duration of hyperglycemia. Chronic diabetes is long, but it is short or gives oxidative stress, which is there in chronic hyperglycemia. In acute stress hyperglycemia, since the body is not adaptive to results in more indicated morbid damage. And that leads to the morbidity is high in diabetes, but that depends on the duration of the glycemic control and the duration of hypoglycemia. Whereas the mortality is somewhat low in diabetes, whereas the mortality in stress hypoglycemia is high. This is one of the important issues. The benefits of insulin therapy, yes, especially in both the cases, but especially in detected and treated in time, it's very important in cases of stress hypoglycemia. What's the effect of hypoglycemia in critical ill patients? It leads to impaired wound healing, increased risk of infection with TPN, increased risk of ischemia, volume depletion, worsened GI motility, and additional impairment of the renal cell function and insulin resistance. Now, as far as outcomes goes, there has been a association between glucose levels and inpatient outcomes, and it is found to be a risk factor in not only in myocardial infarction and other vascular disease in post-cardiac surgery, but also in strokes and in most critically ill patients and trauma patients, and as well as in orthopedic, following orthopedic surgery. Hypoglycemia is an independent risk factor of inpatient mortality, and you'll find that patients with normal glycemic that's the control arm, which is the mortality much less approximately this. That doubles in patients with history of diabetes, and which increases to almost 7 to 8 folds when it is a newly discovered hypoglycemia. It's all right. So that's the key message. One of the key messages is if the blood sugars are less than 100, and when it is between 100 to 200, the mortality is twofold. When it goes to up to 300, 200 to 300, it's threefold. When it's more than 300, it's fourfold. And that's the mortality increase in post-CABG patients. I won't go into details of this. Let's skip that. Hypoglycemia associated with the forest plot showing the same. Beneficial effects. It's not only improves the glucose control, not only improves the cellular function, but also leads to improvement in the function of the molecular and the mediators and the indicators and the selectins, and less of nitric oxide generation and right. I think that's what are the effects of glycemic control? So in the late 90s, one of the first studies in the post-CABG patients by Funari et al. That showed a 65% reduction in infection. Subsequently, it was shown that there's a decrease in mortality to the tune of approximately 60%, and followed by other studies. But this is the Leuven study by Vandenberg in 2001, which first demonstrated that in the surgical ICU, if you control the glycemic status very intensively, there's a reduction of approximately 40% mortality. And later as well, it was found to have other cardiac complications like AFib is also reduced after 2 years. So this is the Vandenberg study, Leuven study, in which the intensive arm included IV insulin administration with a target glucose of 80 to 110, and rather than the conventional one, which is approximately 180. With led to reduced mortality, a reduced incidence of sepsis, dialysis, transfusion, polyneuropathy, or approximately 1/3 to approximately 50% decrease. And this led to further studies. This is another landmark study. This is in post-myocardial infarction patients, the Bigami 1 study in 1999. It first showed that if you intensively control with IV insulin for 48 hours, there's a reduction in mortality, and there's a nice separation, and which is not only beneficial in the early years, but it is also replicated down the line over the years. Intensive insulin therapy in critically ill patients, I won't go into the details. That's the reduction in all the complications. That's the Leuven study. So obviously, reduced mortality, reduced sepsis, bacteremia, reduced recombinant antibiotics, reduced renal failure, dialysis, and length of hospital stay as well. With that, we came to the conclusion of a high blood glucose control, but what was the target? What is the lowest? What is the true low? There were concerns regarding our hypoglycemia, and they found that later studies have actually shown that the severe hypoglycemias were approximately no hypoglycemia. Severe hypoglycemia is approximately 60% increase in severe hypoglycemia as compared to control. Not 60%, almost 30% increase in severe hypoglycemias, rather than no hypoglycemias in the control arm. So if you look at all the studies, the targets, the intensive arm, there is approximately 6-fold increase in the hypoglycemia rate. 0.8% from 6-fold, 5.1%. Vandenberg. That was the medical ICU study, which actually showed another 6-fold, but there was no reduction in mortality in the study. Subsequently followed by other studies, and last of all the studies, which is very important, is the My Sugar study, which showed approximately increase in mortality, increase in the incidence of hypoglycemia by approximately 12 folds. The YSET study, in which the voluminous substitution and insulin therapy in severe sepsis, the study was terminated because they found increased mortality secondary to the increased risk of hypoglycemia. Next was the glucose control one, in which it was also stopped because of the early events of the tight blood glucose control. Next came that's the landmark study, the no glycemia intensive care evaluation and survival using the glucose algorithms regulations. Multicentric study, 42 centers, more than 30,000 patients, and one target was and one of the targets, the usual target was less than 180, and the intensive target was 81 to 108, and led to increased mortality more in the strict control group, 27% versus 24%. In the mortality because of cardiovascular causes are more common in the intensive arm. And this increase in cardiovascular complications was secondary to hypoglycemia rather than anything else. Now, the rate of organ failure was same in both the groups. And so high glucose control meta-analysis. So high glucose control versus usual care, no significant difference in mortality, and high glucose control was significantly associated with higher risk of hypoglycemia, which is approximately 6-fold. There's a meta-analysis of the Trenchanitis randomized control studies. The first plot actually showing favoring the usual care rather than a high control. I won't go into details of those. Hypoglycemia associated with increased cardiovascular complications. In fact, that's not only in acute states only, that's also in chronic diabetes as well. When you're trying to achieve an HbA1c of less than 7%, that leads to increased risk of hypoglycemia as well. And what happens? Tachycardia, high blood pressure, myocardial ischemia, and silent ischemia especially, or angina or infarction, there is increased transiently a prolonged QTc and increased QT dispersion leading to increased incidence of sudden deaths. So treating hypoglycemia in the intensive care unit, limited role of oral agents, baseline insulin, supplemental, and the IV insulin. All of you are mostly aware of this, but in fact insulin is the most powerful powerful weapon in the infantry, and that's the analog, that's the common insulins we use. I'm not going into details. Only thing in the hospital setting, the short-acting preparations might be, and the long-acting preparations might be beneficial, especially in the short-acting, in cases where the PO intake is not consistent and you're not aware of how much the patient is going to take. Essentials of a good IV algorithm, easily implemented by nursing staff, also able to seek blood glucose via early blood glucose monitoring, just to the insulin sensitivity of the patients. And there's various protocols, the Portland protocol, the Yale, PD1, the Levin protocol, but whatever protocol you can introduce within your setting and you can actually implement and that works, so that's important. The easiest protocol is a random blood sugar in milligrams per dl divided by 100, which should be the infusion rate dose. That's the usual starting dose, and you can modify from there. Blood sugar levels, role of insulin, I'm not going into details. Changes because the blood glucose level affects the changes in the mitochondria of the liver. No direct effect on the mitochondria, however, through its effect on the blood glucose levels, leading to increased oxidative stress. So this is important in the insulin requirements in health and illness. In a healthy individual, this is the basal requirement, and this is the prandial requirement, and this is the correction dose the patient might need according to the blood sugar trending. Whereas in a sick individual, the basal requirement is almost static. The prandial requirements are less, and the correctional doses are can vary. And whereas the nutrition, depending if the patient is sick or ill, the nutritional, depending on the amount of nutrition, the prandial requirements vary, and the correctional dose can be important. But what is important, we won't go into details of that, blood sugar. These are one of those protocols, the Mayo Clinic protocol. But what is the ADA or the ACE 2010 target blood glucose levels in the ICU patients or intensive care patients? Insulin infusion should be used to control hypoglycemia. Starting threshold of no higher than 180 milligrams per day, and once IV insulin is started, the blood glucose should be maintained between 140 to 180. So bottom line is less than 110 not recommended, and more than 180 not recommended. What is recommended is 140 to 180. 110 to 140 is acceptable. That's important message. In the non-ICU setting, so admission of hypoglycemia is also associated with adverse outcomes, even in the non-ICU setting, and that too not only in diabetes patients, but also new onset hypoglycemia or stress hypoglycemia. Other medical conditions, infection data did score blood glucose levels of less than 130 milligrams per day. Few of those studies did show between 125 to 180 led to a 10% decrease in infections if the blood sugar levels were more than 180. Stroke data supports blood glucose levels less than 130. Pregnancy data supports mean blood glucose levels less than 110. Again, in the non-ICU setting, the premium glucose targets, as far as the ADA ACE guidelines in 2010, the premium glucose target should be less than 110. Random blood glucose for the post-treatment targets should be less than 180. But to avoid hypoglycemia, we assess the insulin regimes, and if it falls less than, especially if it falls less than 100, one must be very aware, very much cautious about hypoglycemia, especially with the blood glucose of less than 70, and give some supplemental dextrose. And if there is severe hypoglycemia or the patient is symptomatic with a blood glucose level of less than 40. So it's the blood glucose data. We won't go into details of that, but again, as far as this is with correctional dose of insulin, and this is with the basal and prandial groups of insulin. So with a sliding scale and usual mode of treatment, there is an increased incidence of hypoglycemia. So in terms of treatment, let's go into, this is the GAMI-1 study. We won't go into details. So in the non-ICU setting management, let's skip this slides.
let's get this. So what is the considerations of non-insulin therapies? Metformin contraindicated with decrease in renal function, use of contrast media, and any state of poor tissue perfusion like heart failure or sepsis. Cazolinidione shouldn't be used because of associated edema times, low abdominal states, and congestive heart failure or vascular dysfunction. Alpha-glucosidase inhibitors are weak glucose-lowering agents. Amylin, GLP-1 agonists cause nausea, and sulfonylureas can cause prolonged hypoglycemia. This is why we won't go into details of this. Let's skip this. Let's skip. What is more important? The limitations of sliding scale insulin, which is commonly used in most hospitals. It's a retrospective approach rather than those in reaction to a single retrospective blood glucose measurement, and does not take into account either the glycemic trend or the direction in which the blood glucose is moving, either if it's moving up or moving down. That's very important, and does not provide a basal insulin coverage, which is most important in common garden type 2 diabetics. And it provides only supplemental coverage after hyperglycemia is already occurred. So, and does not consider the nutritional changes or the diurnal insulin requirements. Non-physiologic dosing places the patients more at risk of large fluctuations and increased risk of hyperglycemia. So, if you use such a scale, you might be right 1/3 of the time, but it works at occasions, but very, very rarely. But obviously, you put on, depending on the patient's status, put on basal bolus regime, which is more important, and increased incidence of hyperglycemic and hypoglycemic episodes. And so basal bolus regime, one should try to mimic the normal physiology as far as practical, with breakfast, lunch, and dinner. When the patient is not eating, and just give a basal dose and see what are the blood glucose values. Okay, so we won't go into details, but in this I must mention the Humalog, one of the short-acting, one of the insulin, short-acting insulin analogs. What happens in normal insulin? There are two chains linked by sulfide bridges, the B28 and the 29. This is what happens in normal human insulin. It is in 28 there is protein, in 29 there is lysine, and we try to switch that, and that leads to the rapid dissociation of insulin from the subcutaneous tissues, and it doesn't take 30 minutes to act. And efficacy, well, it's more important. Obviously, normal insulin, this is the, after giving a normal insulin, this is what happens. So obviously, approximately 40% increase in the insulin in the postprandial state after 30 minutes. And this is what happens with the Humalog. And because of this, there is increased incidence of hyperglycemia to the tune of approximately 40%. So with that, I'll quickly touch upon diabetic kidney disease. First of all, a definition. It's a clinical syndrome characterized by persistent albuminuria, more than 300 milligrams per 24 hours on at least 2 occasions, at least 3 months apart, and patients invariably associated with hypertension, and such that it may be considered part of the syndrome. Diabetes, one of the common causes of ESRD to the tune of 45%, whereas hypertension is 30%, and rest of rare causes 20% secondary glomerulonephritis, or less than approximately 5% is polycystic disease. This is confusion of the nomenclature between diabetic nephropathy versus diabetic kidney disease, and under clinical circumstances, we don't need a renal biopsy results, and so nephropathy is not the correct term. For patients, clinicians, and caregivers, the term has been changed to diabetic kidney disease by the KDOQI in 2004, and that's how it runs now. Pathological manifestations, I'll quickly touch upon that. It's a glomerulopathy, which is manifested by mesangial expansion, the classical KW lesion, commensal with stenosis and neovascularization. Whereas there is associated tubulopathy with associated hyperplasia and hypertrophy, increased tubular sulfur reabsorption, and increased uptake of organic ions. Diabetic kidney disease, whether it's an acquired complication, it does depend on the duration and the amount of hyperglycemia. But strict glycemic control diminishes the risk of diabetic microvascular complications. protein restriction does retard the progression of established nephropathy, and cholesterol is important, especially in type 1 patients. This suggests that it's an acquired disease, but at the same time, it has an inherited part in which it says the incidence rate of diabetic nephropathy peaks after about 15 years, then drops, gradually declines after about 30 years. So, and there is familial clustering, and there are ethnic differences in diabetic nephropathy.